Greetings. Let me first thank the leadership of Texas Gulf Coast GI Society for this kind invitation to talk about endoscopic mucosal resection to the development of endoscopy tech training program. Contributions made from Houston and Galveston. These are my disclosures, and I would like to thank the support from Dr. John Stroline Distinguished Professorship, Mr. Charles Butt and H.E.B. Grant, and Miss Angela Deal, Medical Illustrator. One of the best things that I've done in my career is to come to Texas in 2001, and I would like to take this opportunity to thank my mentors who helped me develop several areas. As a clinician, we all face problems, and this is a problem that I faced in 2001, soon after I joined the University of Texas Medical Branch in Galveston. Here is a patient, a realtor, with a small flat lesion in the hepatic flexure. He was referred to me for endoscopic resection as an alternative to surgery at that time. And when I explained to him the risks involved with endoscopic resection at that time, which included bleeding and perforation, and the perforation might require emergent surgery. Because at that time, we did not have options for endoscopic closure of perforations, he decided to go for an elective surgery. And my surgical colleague, Dr. Gomez, used to share with me that it is a big surgery for a small polyp. As a surgeon, he encouraged me to resect polyps using endoscopy instead of sending them for major surgery. At around that time, the American Society for Gastrointestinal Endoscopy has been very active in pursuing the natural orifice transluminal endoscopic surgery, and that was pioneered by the Apollo Group. And Dr. Jeff Pansky, one of the senior surgeons from Cleveland, wrote this beautiful editorial on the topic how gastroenterologists as surgeons should be doing if they want to get into this field. And as I read this article, one thing caught my attention. And he posed this question along with a lot of other questions that need to be answered by the gastroenterologists to become surgeons. And that question is, how will the tissues be approximated using the endoscope? This was way back in 2002. And that caught my eye, and I've been thinking about it. I must thank Dr. J. Pashrika, who mentored me in my endoscopic research, and Don Powell, the chairman of medicine at that time, and my collaborator, Dr. Ijaz Ahmad, my research associate. And we did a series of animal experiments and developed several techniques for endoscopic closure of colon perforations. The first step that we undertook was whether it was feasible to close colon perforations in the animal model. I must add here, prior to this, there were a couple of case reports from Japan where they've shown that colon perforations occurring after polypectomy could be successfully closed. In our first animal experiment, we have shown that it is feasible to close a 1 centimeter colon perforation. The next step was we wanted to see whether we could create a leak-proof sealing of a 5 centimeter long linear perforation, and we were successful in doing that. One of the problems that we faced when we submitted our papers was we don't have a control arm. So we did a randomized control study, and in that we have shown that by closing perforations using clips, we were able to prevent peritonitis, and also the peritoneal adhesion burden was much less when you close the perforation compared to leaving them alone without closure. As we were doing the experiments, we had our own failure rate when it came to closure of perforations that were gaping wide. And in that setting, we decided to use sutures to close gaping perforations. And eventually, just before the 2009 Hurricane Ike, we have shown that we were able to even close full thickness resections of the colon and create a leak-proof sealing. So during this period, about 5 to 6 years, we have done over 100 experiments to answer a series of questions so that we could go to the next step of developing colonoscopic EMR as part of my practice. I also want to thank two other mentors. One is Peter Kelsey, who I feel that is the father of video journalism, and he taught me about video editing. That was way back in the early 2000s when we didn't have money to buy a good high quality computer that could edit videos. So he taught us video editing, and that was very useful in my practice. And Roy Sitikno, who was on faculty at Stanford, he used to go to Japan to watch endoscopists do EMR as well as ESD, and he taught me EMR techniques by sharing videos and images remotely. By learning video editing skills, we developed a program to record all the videos, and by editing those videos, the EMR technique, I was able to refine my own technique after observing others who have done this before. Another thing that is important when you want to improve a technique on your own is to collect videos and break down the game and then try to tell a story. As part of this, we produced two DVDs for the American Society for GI Endoscopy. One was on endoscopic closure of gastrointestinal leaks. This was when endoscopic closure of perforations was just starting. And the second set was endoscopic mucosal resection of colon polyps. And the production of these two videos has helped me improve my confidence that I could safely resect medium to large sized colon polyps. In 2009, after Hurricane Ike, I moved to the University of Texas, MD Anderson Cancer Center. And let me tell you, my practice since I joined here in Houston, and my focus has been on management of colon polyps. So before we go further, which of the following lesions can be cut by a colonoscopist. You could safely cut uh, benign polyps, lesions with high-grade dysplasia that is still limited to the epithelium, intramucosal cancer, as well as early submucosal cancer when the lesion just extends to the upper one-third of the submucosa, because that's where in the colon, unlike in the esophagus or in the stomach, the lymphatics are quite sparse, and the chance of lymphatic invasion and lymph node involvement with upper one-third submucosal invasion is extremely rare, less than 1%. So, in other words, mucosal lesions and superficial submucosal lesions, even if it is cancer, can be safely cut, and that can result in a curative resection, especially if the cancer is well differentiated and there is no lymphovascular invasion and the submucosal invasion depth is less than 1 millimeter. The margin to be at least 10 micrometers. So now let us talk about the role of surgeon in the management of colon polyps, especially benign colon polyps. So how are we doing in the United States? This is a large study, and over 1 million colon surgeries were done. And if you look at the percentage of patients with benign polyps undergoing surgery, they amount to almost a quarter of them. And when we looked at the trend over the years, many patients still undergo surgery for benign polyps, despite advances in endoscopy and endoscopic resection. The rate of resection by surgeons is still pretty high. Why is this important? Colonoscopy and colonoscopic polypectomy is very safe with close to zero mortality or no mortality and very little morbidity. In contrast to that, surgery has a mortality, even though small, given the advances in surgical techniques and anesthesia techniques. And there is also a sizable portion of morbidity with hospital stay of 4 to 5 days. And, and this is something to keep in mind. So let us look at how are we doing in the great state of Texas. So we did a survey. We presented 4 lesions, uh, laterally spreading non-granular tumors, granular tumors, sessile polyps, at least 20 millimeters or larger. And we surveyed 114 gastroenterologists who attended the Texas Society for Gastroenterology in 2018. And when we asked them as part of the survey, how many of these lesions would they resect using colonoscopy, and how many of them would they send to surgery? It's interesting to note that close to 50%, at least one of these lesions will be referred to surgery in close to 50% of the time. And I want to share with you all these 4 lesions were actually removed successfully by endoscopic mucosal resection by us. And you could see that although endoscopic mucosal resection is successful and also safe in all these patients, in actual practice, in the community, quite a few of them will end up having surgery. So now let me bring you to what we have done in the medical center and especially at the University of Texas MD Anderson Cancer Center. I joined this institution in 2009, and I started the colon EMR program here. And I had only two simple principles. Whenever I saw a colon polyp that looked benign, I asked myself whether I could cut completely so that the recurrence rate is low, and whether I could cut the polyp safely without risking perforation and emergency surgery. Those were my two principles. And we developed a protocol in 2009, and I followed this protocol religiously. Since 2009, I've been following the same protocol. Initially, patients underwent conscious sedation, but in the last 5 to 6 years, all patients were done under general anesthesia. A cap-fitted colonoscope is used, and for submucosal injection, I used only saline with a little bit of either indigo carmine or methylene blue, and I lifted the polyp, and using a hard snare or a stiff snare, I resected them either in an en bloc fashion or in a piecemeal fashion until I saw a clean base, and the resection margin is also clean. I ensured that the resection is clean and free from any overt polyp by taking multiple photographs of the base and photographs of the edge every millimeter. Following that, I've also included ablation of the edge with forced APC set at 0.8 liters and 35 watts till I created a brown effect so that I could destroy any microscopic cells that were lying in the edge that we could not see. I also went ahead and tried to close the defects with clips, complete closure. And at that time, most of my colleagues in the rest of the world were just doing the resection and moving on. But I added ablation of the edge based on one paper that was published by the London group, and clip closure based on my experimental work showing that you could actually uh, approximate the wall of the colon, which is rather thin. You could actually get your clips deep into the submucosa or even into the muscularis propria. And I'm hoping that by doing that, you could also cut off the blood supply from the deep submucosal plexus if that was the source of the bleeding in these patients. All patients were sent home after the procedure, and they were given a strict dietary instruction of liquid diet for 2 days, low residue diet for 2 days, and regular diet on day 5. And I made it a point to call them or ask them to send me an email uh, for the first 5 days. And I contacted them myself by phone to give them their pathology report. And then we followed them at 6 months and 18 months to check for any recurrence. So, how did we do? We published this in 2006. Uh, Anybody who was referred to me for EMR, 203 patients, and we were able to avoid surgery in 3/4 of them. None of them required emergency surgery. In other words, we didn't have any major complications that required surgery. Delayed bleeding rate was pretty low, 3 to 4%, unlike reports that report at least 10, 12, 15%. In my first 5, 6 years, I did not have any perforation, and we had a very low recurrence rate of 3 to 4%. And when you look at it, uh, There are lots of publications in this area with the recurrence rates anywhere between 15 to 20 to 30%. And our study showed uh, the recurrence rate is pretty low. Here, this was a larger population published in 2019, bigger polyps up to median size of 35 millimeters, and still we had pretty low recurrence rate of 4.5% and none required emergency surgery. So how about now? Now we have almost 12, 13 years of experience removing large polyps, 20 millimeters plus. Um, we took care of close to over 500 patients, and 80% of them we were able to cut. Complication rates continues to be low, and recurrence rate also continues to be low. And we had two patients that required emergency surgery in the last 2 years. One was a delayed bleeding in an elderly patient who was treated for lymphoma, who also suffers from von Willebrand's disease, who had recurrent bleeding that we could not control with clipping and who could not be controlled with angio and embolization that required surgery. And another patient, again, a von Willebrand's with von Willebrand disease, underlying cirrhosis of the liver, uh, a Jehovah's Witness, where we cut the polyp and the patient ended up with a delayed perforation that required surgery. So, as part of the protocol that we started in 2009, we did saline assisted heart snare resection or EMR, along with we added uh, ablation of the edge with organ plasma coagulation and routine clip closure. And as I was doing this longitudinal cohort study, I noted that the complication rate was pretty low and the recurrence rate was also pretty low. And because of that, I could not participate in any of the national studies because I didn't want to put my patients in the control arm. And I'm glad that I did not do that because Hycopol has shown that clip closure reduces rebleeding and snare tip soft coagulation reduces recurrence from the Australian group. So I'm happy that whatever protocol we started has taken care of our patients well, and that is something very satisfying. Let me share with you what lessons have I learned by looking at our outcome. As you can see here, we are only 80% successful, 75% successful, and we had patients where we could not help. And when you look at where we deferred EMR, I've noted that sometimes the referring endoscopist may not have picked up the site of cancer, and random biopsies from polyp just showed adenoma. So, learning to figure out whether the lesion has cancer or not is a good skill to have so that you don't put a patient who has a deeply invasive cancer through a piecemeal EMR or even an ESD. I've also failed when, in the first 5 years of my practice when I did not have heart biopsy avulsion technique uh, in my armamentarium. I sent quite a few patients with tethered lesions for surgery. Nowadays, we don't do that. We can actually have very good outcomes by taking time and picking up one grain at a time and have very low recurrence rate. I was not successful in removing polyps that are 5, 6, 7 centimeters, and I felt that it is best for them to go to surgery, especially if they are in the right colon. And some patients have very tortuous colon, and I was not able to keep my scope in a stable position for resection. And if I were to end up with a bleed or a perforation, I felt that I may not control that, and that would lead to emergency surgery. So again, difficult access. I decided to defer and send them for surgery. And there are a couple of patients where the referring endoscopist did not realize that the patient, in fact, had polyposis syndrome, and we felt that it is best for them to go for surgery. So, based on my experience, I want to share with you what happens to a polyp before they are sent to an EMR center. Although this is getting better, but this is what I've seen. Once the endoscopist sees a large polyp, uh, he tries to take one picture, doesn't show the polyp very well, and then he puts in a very brief report with just 1 or 2 photos. But they try to take a lot of biopsies that cause a lot of problem for us because biopsies lead to tethering of the polyp, which makes it very hard for resection. Sometimes I've seen people do a snare resection, either with a cold or a hot snare. Again, makes it very difficult for the EMR center group to take care of them. I've also seen, even recently, injection of tattoo into the lesion, which causes a lot of intense fibrosis and difficult and makes it difficult for resection. And then it's not uncommon even now, patients were told to have surgery without giving them an option about endoscopic mucosal resection. And patients Google and figure out and come to the EMR and ESD center. This is probably what still happens, but what can we do to take care of our patients better? So, once you see a large polyp, it's a good idea to provide a detailed endoscopy report. You may want to share whether your scope was easy or whether it was a technically challenging colonoscopy with a long tortuous colon, because that helps the referral center to plan and schedule a longer procedure. And it is good to describe the morphology of the lesion, and instead of saying 2 centimeter, 4 centimeter, 5 centimeter, for a large polyp, it is better to also mention about the longitudinal extent, whether it's extending from one fold to the next fold, or from a fold to a valley, or the intercostal area, and whether it was involving 25% of the circumference, 50% of the circumference, or 75% of the circumference, which is a better measure, and take as many photos as possible to give us a better idea of what we are trying to deal with. And also, it helps us kind of counsel the patient better. When it comes to a cecal lesion, make sure to comment on whether the cecal lesion is going deep into the appendix or not, because we can't cut polyps that are going deep into the appendix. And if it is involving the ileocecal valve, how much is it involving, whether it's going into the TI or not. It's a good idea for all endoscopists to learn about NICE classification and identify cancer. And if you're sure it is cancer, take targeted biopsies to document cancer and refer them to surgery. And if it is not cancer, you want to take one biopsy, maybe, or even not take a biopsy if it is not cancer, and place a tattoo 3 centimeters distal to the lesion in the same plane with creating a submucosal bleb first and then filling it with tattoo. Make sure to avoid the temptation of taking multiple biopsies, avoid the temptation of snare resection, avoid the temptation of putting a tattoo into the lesion. And try to put in a detailed report, especially with a lot of color photos. That helps the EMR center to do a better job and plan the procedure well. I must share with you that we are very fortunate to have a lot of brilliant uh, and exceptionally skilled endoscopists at Baylor, Mohammad Atman and his group, and at MD Anderson, uh, Philip G., who trained with a Master ESD expert from Brigham, and Sunil and his group from Methodist, and also Nirav and his group from UT Houston, who could provide a full spectrum resection service at our Texas Medical Center. What can we do to improve the care of patients with colon polyps, especially benign polyps? I feel that lesions that are 15 to 20 millimeters, we should be able to resect so that the patients can move on with their life rather than going to an EMR center. And I've put in actually recorded videos, videos that show what all I've done, not to just show how well I've done, but everything, my mistakes, everything in a compilation of 358 EMR videos that are available on my YouTube channel. I hope you find them useful if you want to learn certain techniques. And from now onwards, I'm going to record more videos with an audio commentary that can help you. One of the things that is important for all of us as we practice high quality endoscopy, doing advanced procedures, is the technical support or the assistant or the technician. When I moved from Galveston to Anderson, in the interim, I practiced in a community hospital, and I realized that compared to what I had at UTMB, the technical skills of assistants in the community hospital was not optimal. And that has kept me bugging, and that eventually led to the development of an endoscopy technician program. And I would like to take a few minutes to share that story with you because this is something that happened at the Texas Medical Center with the help of my endoscopy colleagues, especially Cal Patel, and industry partners, Tom Slocum, and my own endoscopy technician group, Laura, Lieben, Sophia, Marcella, as well as other nurses and technicians from the medical center. So we started with this idea of developing an endoscopy tech training program. I pitched this idea to the chancellor of the Houston Community College, and he introduced me to the president, and we went through several steps, developing a curriculum, creating an advisory board, getting the curriculum approved by the Southern Association of Colleges and Schools and the Texas Board of Higher Education, 35 credit course material, out of which 19 credit hours was purely endoscopy theory material. And because the community college doesn't have experience in training endoscopy technicians, with the help of endowment support from John Stola Distinguished Professorship, Mr. Charles Butt's HEB grant, and the MD Anderson Cancer Bootwalk program, we were able to develop 19 credit hours of course material with the help of an educator, Sanjay Suresh, and a medical illustrator, Miss Angela Deal, and we created richly illustrated material so that the technicians don't have to buy any books. And we supplemented that by creating audio narrated videos for every uh, course lecture material. And these are also available. We gave it to the community college, but this material is also available on the YouTube. If your technicians want to go through that and learn, this is a resource that you have. I'm excited to share with you that we had 13 students who enrolled and one had to drop off. 12 students graduated. Most of them had over 80 to 90% scores in their classes, and 80% of them signed up for jobs before they graduated. And within 2 months, 100% were fully employed. I hope you could help. I would like to make an elevator pitch that is uh, maybe your practice or maybe your ambulatory surgical center or maybe your hospital endoscopy unit could adopt a student. Uh, the price of education at the community college is relatively easy, but most of the students have applied for financial aid, and I hope you could consider adopting a student and help them. What else did we do? I felt that it is important for us to develop the team. Although endoscopy has ripened to the full extent, we can almost do everything that a surgeon can do, but not in a major way, but in terms of replicating the techniques, cutting, closing, anastomosing, controlling bleed, etc. But we have to develop the team so that we can continue to provide exceptional care. The American Society for GI Endoscopy, just celebrated their 80th year last year, and for the first time in 80-year history, they opened up membership for endoscopy technicians. You know that they have a beautiful online learning uh, website, the GI Leap, and they have created GI endoscopy technician training program on the website, and we are exploring the opportunity, exploring the possibility of developing endoscopy tech certification under ASGA. I want to thank you all for your time, and I'm really grateful for this opportunity. I want to say special thanks to many of my colleagues here in the medical center who have done an amazing job in developing the program. And I want to thank Cal Patel in particular and other members of the Texas Interventional Endoscopy Group who pitched in to make it possible. Thank you.